So we are going to start with the last talk, and we're going to try to make it quick and easygoing. Lymphedema, clinical presentation and treatment. So, lymphedema. How did I become interested in lymphedema? First of all, I started doing veins because I told you I had an aortic valve replacement 10 years ago, and by microridon, and that changed my life. So I was in the recovery room in Fondren Brown, and my wife told me, I told my wife, I don't know what I did this, it's hurting like Dickens. So she said, because you need to walk your daughters down the aisle. I never saw my daughters. I was in the hospital all the time doing thoracoabdominal, doing triple A's, doing carotid aneurysms. So I decided to change my life and start doing veins. It's difficult. Little bit disagreeing with Dr. Bush in the sense that, yeah, you guys do thoracoabdominals and this is not, no, this is difficult also, and it's tricky the way we do veins. It's not that easy, and that's the pitfall of veins, because people think, oh, it's just veins, anybody can do it. It's not true. It's different type of stress, requires different skills, but it's difficult. So I started doing veins. And then I started seeing patients, especially females, with swollen legs and normal veins, normal venous system, no venous insufficiency. Out of my 24 months of training in Baylor, back then when I was with Lumsden here in Methodist, we have 2 talks about lymphedema. One of them awful, and the other one was decent by Dr. Globisky, but that's it. So really lymphedema is if vein phlebology is the stepchild of vascular surgery, lymphedema is the bastard of vascular surgery, lymphatics. And nobody wants to deal with that. So I started getting involved in this because I figured if I'm going to do this, I'm not going to be the guy that reads 3 articles and pretends to be an expert. There are a bunch of those. So I went ahead and got certified myself as a lymphedema therapist, start different type of certifications, including the Lymphedema Association of North America. So, because I think this, like the venous malformations that Dr. Lumsden just mentioned, these patients don't have a home neither. And frankly, the reason why they don't have a home, and I'm going to be blunt and not politically correct, sorry, is because we are a bunch of easy people that we don't dance if there is no money. There is no money in lymphedema. That's the truth. Why am I going to spend an hour treating the patient with lymphedema and get $144 when I can do in an hour 3 venous ablations back to back and make almost $6,000? Flat out. That's why lymphedema hasn't progressed in this country. There is a bunch of clinics, MD Anderson, Sloan Kettering, blah, blah. Nobody does a comprehensive lymphedema treatment. The only place on this good earth that is worth a damn is the Foldy Clinic in Hinterzarten, Germany. That's it, period. This is the mecca of lymphedema treatment. So now, we are at crossroads in this country right now because Medicare just lifted the cap for physical therapy. That'll give us the break we need to start treating these patients correctly. And you'll see what am I talking about when I talk about the management. So quickly, lymphedema, classified in primary and secondary. The congenital classification is time of presentation. Is self-explanatory. The most common is the precox, 2 to 35 years of age, with 77 to 94% of the patients. Secondary, this is an arbitrary classification based on breast cancer. There is no really time to classify secondary lymphedema, but it's less than 2 months and more than 20 months between early and late. Regarding the etiology, primary, congenital, again, younger than 2 years, most of them are just genetic problems, of course. Precox, mixed disease, and sporadic, that is the most common. Again, sporadic, what does that mean? I don't know. We just sound like we know what we're talking about. Sporadic, okay? I don't know what causes it, but it's the most common. And of course, lymphedema tarda when it's older than 35 years old. We have no clue what comes. The patient just shows up with swelling that they never had before, has no apparent predisposition to develop this. So the most common cause of, obviously secondary lymphedema is more common than the primary. The most common cause worldwide is filariasis. mostly in undeveloping countries. Developing countries, cancer is the most common, the most common cause of lymphedema. Of them, breast cancer. But there is also trauma, and this is when it becomes a little bit dicey. Trauma is not just fractures, contusions, car accidents, etc. Surgery is trauma, and that involves us guys, that we are going to put a knife on this patient. Chronic infections, not only in the genital area, but in the cellulitis, recurrent cellulitis, etc. And also chronic edema. If the patient has swelling, because any other reason, CHF, DVT, renal failure, whatever, and that swelling in the lower extremities lasts longer than more than 3 to 6 months, as a rule of thumb, it will affect the lymphatics that they were not affected in the first place. So it becomes lymphedema up to a certain point of time. So you can say almost with certainty that a patient that has CHF and has had uncontrolled edema in the lower extremities for more than 6 months has some lymphatic involvement at that time, period. So talking about lymphatics, this is typical drawing from anatomy about the superficial lymphatics, okay, the lower extremity. What do you think happens when we do a femdistal bypass? I'm not saying we shouldn't do femdistal bypass. I'm saying we need to consider the risk and the damage we're doing to the lymphatics, so be proactive. Of course, the patient needs the bypass to keep the limb and keep functional and try to return to a normal life. But what are we doing with the lymphatics? Nobody says anything. Nobody knows anything. Nobody ever told me about lymphatics when I train. So, and these are the patients that they are going to get edema afterwards, and 99% of the time we blame it at reperfusion injury. Oh, it's swollen, it's a reperfusion injury. Yes, but it's not the entire story. And we are not being proactive to control lymphedema that might become disabling for these particular patients. Now, this is another classification. The lymphoangiographic is a little bit more complex. Again, Alan mentioned that this is going to be posted in YouTube. You can go over those classifications. There's tons of them, so we don't need to spend much time on this. So, again, second take, we already saw these slides, but let's go again. Lymphedema is a chronic lifelong disease. Stage 0, latency, the patient that had a trauma and no swelling. But, you know, it might start with heaviness on the lower extremity, of sensation of tightness, or the patient feels the leg swollen, but there is no obvious physical change. And we dismiss this patient as probably needs another vacation. No, it might be stage 0 lymphedema. Stage 2 is a clinical when it becomes edematous, again, more prominent at the end of the day than in the morning, but has the stemmer signs positive. Remember what I told you. Stage 2 is clinical fibrosis. This swelling, this edema that is not fluid anymore doesn't go away in the mornings and it's permanent. And lastly, stage 3, lymphostatic elephantiasis. Again, the sign, stemmer sign, is pinching the dorsum of the second toe. If you can pull the skin together, that's negative. Most likely that patient doesn't have lymphedema. If it's positive, there is no question about that. Square foot, toes, but most likely because the shoes, again. Orange peel, most likely, more commonly in breast cancer. Buffalo hump, hyperkeratosis, the inflammatory response of the accumulation of the keratin for desquamation. And when they start lumping up, is papillomatosis. Lymphorrhea is basically any fluid that leaves the skin without any visible injury. And we saw the physiology of lymphatics earlier. Fibrosis, swelling, and hypoplastic concave toenails. So, cancer. The more aggressive the surgical treatment, the more risk to develop lymphedema. One more time, I'm not saying we shouldn't operate on these patients. Of course we do. We need to, but you need to be proactive. If, of course, you are not going to do general surgery, but if you are going to do a surgery on these patients, you need to start thinking about lymphedema afterwards, not just pretend that doesn't happen to you, or my patients don't develop lymphedema, or, oh, it's resolved itself. BS, it's not true. It's not true. So, age, the older the patient, the less chance to develop lymphedema. Why? It's just time-wise. By the way, once the patient has been exposed to a risk factor to develop lymphedema, it never goes away. So patients that I interview, what happened to you? Do you have a hysterectomy? Well, yeah, I had a hysterectomy. It was a mess. I bled. They took me back twice, blah, blah. But that was 40 years ago, doctor. It doesn't matter. The risk is always there. And get this, the trigger factors sometimes are common things like flying. How many times have you had patients that go in the flight over across the Atlantic and they land in Europe and the leg is swollen? The first thing you need to rule out, of course, is DVT. But once that is gone, lymphedema. It's typical. Depressurization is a trigger factor for lymphedema. Another story. Patient after breast lumpectomy and sentinel lymph node dissection for breast cancer 5 years ago, goes to the routine mammogram. The technician is a little bit rough, presses the breast a little bit in a rough way, and what happens? A week later, starts the lymphedema that she never had. So those trigger factors are real, and they happen all the time. Obesity, no question, 60% of the obese women at the time of diagnosis of cancer will develop lymphedema, and it's even related to the cup size of their undergarments. You can see there the numbers. And as I said, the more aggressive the surgery, the more risk of developing lymphedema. I'm not going to read all the numbers, but it's what all these slides exemplify. Cervical cancer is the same thing, 21 to 49% after surgery and radiation. And endometrial cancer is in the same ballpark. In males, prostate cancer, 20 to 30, when the patients go to a limited pelvic dissection, if it's radical, doubles up, period. Melanoma, as well, is the skin cancer most commonly related to lymphedema. And when it goes to an inguinal dissection, 30% develop lymphedema. Surgical treatment, just for get that pruritus out of our talk, because we are surgeons, okay? So they are divided in epiphyseal lymphadenopatous tissue remove, excisional procedures, that is removing basically the excess of lymphadenopatous tissue, or microsurgical that does basically anastomosis, and either to veno-lymphatic anastomosis, lympho-lymphatic anastomosis, or lymph node transplant. And this is the deal, like anything in literature, everything right whatever they need to get published, and sometimes it's not true. All these papers that I found, great success, and then 10 years later they do a meta-analysis. They couldn't justify the statistical success. So I took the numbers of somebody that I trust, that I respect, Dr. Globisky, and these are the numbers of surgical treatment. They are not that good. They are not that good. So surgical treatment is reserved for patients that are refractory to medical treatment, to a comprehensive lymphedema treatment. That is what they are doing in Germany. That when I started seeing these patients, I thought, well, we need to at least take these steps to try to help these people. And then I went to a National Lymphedema Network meeting in Dallas, and I saw Tobias Birch talking about this, and I was like, well, that's my idea. Well, it's not. I mean, they've been doing it for 100 years, So, but it is an involvement of 3 areas, basically health, function, and psychosocial, and needs to be done. The comprehensive lymphedema treatment involves medical, nutritional, psychological, physical, and any ancillary things. Let me tell you this. As a doctors, we are going to address whatever we can address regarding lymphedema. If it's venous insufficiency worsening, we need to do that. But these patients, especially breast cancer patients, please don't tell me that they have a normal psyche. It's a trauma going over that surgery, and ladies know that. And that can lead to depression, increased calorie intake, obesity. It's just a cycle. We cannot just do the treatment and leave the patient with the same weight, 300 pounds, period. You can't do that. So you need to do it comprehensive. If you just address the lymphedema with bandages and massaging and that's it, and don't address the rest of the problems, you are milking the system, period. And that is not what we are trained to do, I want to think. So the complete decongestive therapy has 2 phases, intensive and maintenance. The intensive phase lasts about 2 to 4 weeks, and is going to do the manual lymphatic drainage that needs to be trained to do that. Is the manual lymphatic drainage is very, very specific massage in sequence of events around the affected area. It's not traumatic, it's not hard, it is completely different what I expected. As a surgeon, you see a swollen limb, you want to put pressure, you want to put muscle, try to get the water out. Very gentle. At the beginning, when I started learning, I said, this is just a waste of time. This is just snake oil. That's what I thought. But then I started finding proof of this, and then things change. So this, again, is to control the patient in the first 2 to 4 weeks, and that requires some compressing bandages. And we need to tell the patients that this is like a fracture, that is going to have a cast, because the bandaging is thick and bulky, and they are going to get scared. Oh, I'm not going to wear that. It's just 2 weeks until we control it. Same like when you break your leg, we need to put a cast. It's not forever. It's just to heal the bone. Same here. And then you pass to the maintenance phase, in which you are going to teach the patient to wear compression stocking, do self-manual lymphatic drainage, skin care, pneumatic devices to keep the results for the longest time. And the objectives, of course, are logical. Common sense objectives: edema control, increase lymphatic drainage, decrease the fibrosis, decrease the rate of infections, improve the function, etc. So he has demonstrated the complete decongestive therapy, has demonstrated 80% success, but needs to have full commitment of the patient. This is not a political correct treatment. Not everybody can have it, because they need to understand what you are doing in order to cooperate. As a matter of fact, the patients that you will see in a minute, the first thing I tell them, 30 to 40% is my job, 60 to 70% is yours. You cannot be wrecking your body and come here and think that we can fix it. So they need to have full commitment to fix this. This is, again, the technique that I showed you earlier about the fluorescent imaging. And this is before the MLD, before starting the manual lymphatic drainage. That's the ankle. And then you see what happens as soon as we start that gentle, light massage. I mean, this, when I got a hold of this video, it blew my mind. Because how is possible that such a gentle massage just at the tip of in the forefoot can produce that much drainage? It does, period. Some people think it's not possible. It is. So, and like I mentioned earlier, there is no cure for this. This is a chronic disease, and the patient needs to be taught how to do self-manual lymphatic drainage. So, ancillary products like pneumatic pumps, they help because it's for the rest of their lives. They cannot be doing this every day. They're going to get tired, they're going to get fed up, and they are not going to quit. One word about this other compression stockings and ancillary. One thing is the prescriptions that you give to the patients based on you and your peace of mind. And the other thing is what really happens. I love when people stand on stadium in the podium in big meetings. Oh, that patient needs a 30 to 40 millimeters. Really? 79-year-old woman with arthritis is going to put a 30 to 40 millimeters of mercury compression stockings? You're kidding me, right? But they leave the podium because they say the right thing. It's not what is happening. So you need to be realistic what is happening with those patients. Sometimes you need to give suboptimal compression knowingly and tell them, you need 20 to 30, 30 to 40, but there is no way in this world you are going to put it, ma'am. I'm going to start with 15 to 20 and try to get some benefit out of this. That's the real medicine, know what is in those areas. And like always, a phrase that I hate the most is, for your test, answer that. But it's not what happens in real life. And you need to be realistic because you are not doing any favors to the patient by writing 30 to 40, more than 40. Really? It's not going to be able. So it's important you consider that in your practice. How can we assess the result? There are objective by volume and range of motion. There are programs that are designed to calculate the volume according to external measures and see the progress, and also programs to see the motion and angles and improvement in the function of the affected extremity. The subjective, obviously, is more psychological, emotional, and social function. And some of the papers show almost 50% improvement on the psyche and function socially of these patients. The volume is clearly improved up to 60% in some of the papers. This is a patient that came to my office. I don't even know. This is before I start. When I started just showing signs of interest for lymphedema, people start showing up. You build it, and they will come. And I haven't built anything, and they keep coming. So this lady, 5 years with right lower extremity edema. Her OBGYN did an ultrasound, no DVT, just put compression stockings. That's it. So we start treating, did acute treatment for 2 weeks, and this is a month later. Let's see. Engineer from NASA, retired. Same story. This is 2 months later. I mean, it was controlled right away. I'm just showing you that when proper people, when they understand what they are doing, it can be controlled. Even this gentleman, good old boy from Needville, venous ulcer, this is 6 weeks later. The same guy, same patient, the other leg, this is 6 weeks later. And this is just with compression stockings, no massaging anymore. He does massaging every so often, but he's not compressive bandage 24/7. And of course, my star patient, this lady came to my office, 400 pounds. I told her, I can't treat you. She started crying. I said, sorry. I haven't signed. This is no political correctness here. I'm sorry, I can't treat you because it's going to be a waste of time. So she committed herself. She said, I'm going to do it. I'm going to do it. I'm going to do it. This is 3 months later. Change your life. Not with a knife. And don't get me wrong, I love surgery, but there are things that we need to open our noggins and see other alternatives for patients that are going to come our way. And she committed so much that went from 400 to 287 so far, and we're still working in progress. Changed her life. But not everybody. You know, I have these 2 patients that I told them, this is what we need to do. Oh, of course, doctor, I'm going to be here. Give me the first appointment. They never came back. This treatment is not a politically correct treatment. It's not for everybody. They need to understand what they are getting into. But you can help patients like this. I saw a movie. I don't know if you have seen this movie. Just came across Netflix. I was tired, bored. Best movie I ever seen in years. It's about one of the great physicians in the 11th century in Persia, Avicenna. But within this movie, one of the barbers, who is played by this guy in England, is training this guy about being a barber, you know, pulling teeth, draining abscesses before he goes to Persia and tries to learn more about from Avicenna. And he tells him one phrase that just percolated into my brain and soul. We need to be grateful for the profession we have. We are taking care of the most precious thing on this earth. And we many times forget about that in the voraginy of this, the system, the stress, the payments, the dues, the whatever. We have a profession like no other. So thank you guys.